Inequity and lack of access is a determining factor in health and development for children in all societies, from the poorest countries to some of the richest. Unfortunately, barriers to good quality healthcare still exist for children who by no fault of their own are born into poverty, a social group that faces discrimination and bias, and also in circumstances where their caregivers have poor health literacy. So thanks very much to our brilliant speakers today. They're going to have a panel discussion to talk about this and about how we can use quality improvement tools to address this inequity. So I'll just give an introduction to each of our speakers. We have Dr. Ulfat Shaikh, who is a professor of pediatrics and practices and teaches pediatrics at the University of California, Davis Health. Ulfat is chair of the American Academy of Pediatrics Council on Quality Improvement and Patient Safety. The focus of Dr. Shaikh's work is leading clinicians in designing, implementing and evaluating health systems improvement methods across a broad range of healthcare settings to improve health and delivery outcomes. Dr. Shaikh also conducts coaching and training programs for health professional trainees, clinicians and staff in clinical quality improvement, patient safety and healthcare delivery science. Dr. Shaikh is also the associate editor of PSNet, a national web-based patient safety resource funded by the Agency for Healthcare Research and Quality. We also have Joel S. Teeter, who is a professor in pediatrics in the Division of Hospital Medicine at Seattle Children's Hospital and the University of Washington. He's recognized as a national leader in quality improvement and research, and is the immediate past chair of the American Academy of Pediatrics Council on Quality Improvement and Patient Safety, where he led the council's anti-racist framework to address health disparities for children. He has helped lead and mentor many research and education projects aimed to improve the quality and equity of healthcare delivery, including a recent study in JAMA Pediatrics, examining the use of race and ethnicity in national guidelines, and a popular health equity training called Teamly, or GATHER is the acronym. We also have Dr. Peter Lachman, who most of you know would be is the former CEO of ISQua as well. Peter is lead faculty quality improvement at the Royal College of Physicians of Ireland in Dublin, where he directs the leadership and quality programme to develop clinical leaders in quality improvement. He was a Health Foundation Quality Improvement Fellow at IHI from 2005 to 2006, and as Deputy Medical Director for Quality Improvement and Patient Safety, he introduced QI and patient safety programmes at Great Ormond Street Hospital in London. He was a consultant paediatrician at the Royal Free Hospital in London, specialising in the challenge of long-term conditions for children. Dr. Lachman was the National Clinical Lead for SAFE, a Health Foundation-funded RCPCH programme, which aims to improve situation awareness in clinical teams across England, programme across Ireland. He's the lead editor of the OUP Handbook on Patient Safety, published in April 2022, co-editor of the OUP Handbook on Medical Leadership and Management, published in December 2022, and editor of the OUP Handbook on Quality Improvement, that's going to be published this year. Next we have Dr. Meghan Drayton-Jackson, who is an assistant professor of pediatrics at Indiana University School of Medicine and Riley Hospital for Children. She's a hematologist and primarily cares for patients with sickle cell disease. Dr. Drayton-Jackson serves as the chair of the Riley Pediatric Centre for Cancer and Blood Disorders Quality Council, and educates, leads and participates in QI and patient safety work throughout the hospital. In addition, she is a co-chair of the AAP COQUIP's EDI committee. Dr. Drayton-Jackson also has a Master of Business in Operational Excellence from the Ohio State University. She uses her knowledge of quality improvement and patient experiences to advocate for improved systems and processes for equitable quality care locally, regionally and nationally. And next we have Isabela Castro. Isabela is a global patient advocate and a board member at the Beryl Institute and at the WHO Patients for Patient Safety, US Patient Safety. Isabela transformed specialised dentistry to treat people with disabilities, geriatric dentistry, home care dentistry, and hospital dentistry, bridging dental care to other healthcare areas, not only at the Air Force, but in every setting she worked. Isabela's experiences vary from public, private, and military hospitals and home care to experience in healthcare operations and management. She's been involved with quality improvement, risk management, and innovation initiatives, and is well versed in working within new cultures, matrix leadership teams, and takes pride in not accepting the status quo. She's a global activist with the world movement What Matters to You, and patient advocate through her work at the Beryl Institute's Global Patient and Family Advisory Board, as well as on the Plaintree International Patient and Family Partnership Council. So I don't know where they get the time to do this webinar, but delighted to have everybody here because they're all very busy people by the sounds of it. So I'm going to hand over to you, Ulfat. Thank you very much.
Great. Thank you so much, Katrina. So welcome everyone to our second American Academy of Pediatrics Council on Quality Improvement and Patient Safety and ISQua joint webinar. The first one was on home medication safety that I had Dr. Julia, one of our physicians that works with the AAP on, and this is our second webinar. So in this webinar, I just wanted to start off by making sure we all are familiar with the terminology we will be using today, just to make sure that we start off with the same vocabulary and the same definitions. And all of you are probably familiar with the 6 domains of healthcare quality, where high quality healthcare is safe, timely, effective, efficient, equitable, and person-centered. And in today's webinar, we will be talking a lot about the domain of health equity, specifically providing care that does not vary in quality because of personal characteristics such as gender, ethnicity, geographic location, and socioeconomic status. So the World Health Organization's definition of health equity is the absence of unfair, avoidable, or remediable differences among groups of people, whether those groups are defined socially, economically, demographically, or geographically, or by other dimensions of inequality, such as sex, gender, ethnicity, disability, sexual orientation. And the WHO says that health equity is achieved when everyone can attain their full potential for health and well-being. So many of you are probably familiar with this graphic that states the difference, that shows the difference between equality and equity. And equality is when everyone's sort of given the same amount of resources. However, as you can clearly see, depending on where we are in society and what we have in our environment, we may or may not be able to access the same level of health. And so equity actually tries to break down those barriers and give everyone a chance at access and good health. So health disparities, the CDC definition that I'd like to share today is preventable differences in the burden of disease, injury, violence, or in opportunities to achieve optimal health experienced by socially disadvantaged racial, ethnic, and other population groups and communities. So there are several conceptual frameworks on social determinants of health. And the one that we will share today at this webinar is the one that the WHO has on its website. Health and healthcare disparities are frequently viewed through a lens of race and ethnicity. They also occur across a range of dimensions such as socioeconomic status, age, geography, language, gender, disability status, citizenship status, sexual identity, and orientation. So on the WHO website, if you want to explore this further, there is one of these conceptual frameworks for action on the social determinants of health, which play a role in health equity. The other resource that I wanted to share is this graphic that I got from the American Association for Cancer Research, where they talk about healthcare disparities in cancer. Specifically, in cancer, they found that ancestry, race, ethnicity, socioeconomic status, health coverage, people who live in certain geographic locations, specifically rural area, LGBTQ plus people, refugees, immigrants, asylum seekers, individuals with disabilities, teens and young adults, and the elderly are other groups that face a lot of health disparities. So why do health and healthcare disparities matter? We have in pretty much any of the countries that are probably represented on this call, seeing a more diverse population. There's short and long-term harms to populations who face disparities directly. But in general, in addition to the populations that face disparities and the problems they face due to it, there are limited gains in the quality of care and healthcare for the overall population as well if we don't pay attention to these issues. There's increased costs of care for a healthcare system as a whole, and healthcare disparities are at their root unethical and unjust. So there are several challenges to addressing health disparities. We've been working on this for many years and have had some gains, but there is still room for improvement. There are healthcare policies, health policies, government and organizational priorities that play a role in decisions, health insurance and payment mechanisms in the countries we work in. Our capacity to address social determinants of health is highly variable. There are limitations in funding for prevention and public health, the healthcare workforce issues, and there are gaps in data to measure and track disparities, which is where in many of these areas is where quality improvement comes in. And then, of course, the COVID-19 pandemic has led to just all sorts of health disparities that have emerged, that many of them stayed beneath the surface, and now we see them. There's healthcare access, of course, but then with the rapid rise of telemedicine, we saw access issues with telemedicine, with technology. There's COVID vaccine testing and COVID testing and COVID vaccine variation and how available and accessible that is. We saw a lot of mistrust in the healthcare system, language barriers. There's built environment issues with neighborhoods that were overcrowded, households that were overcrowded, experiencing more sickness due to COVID, barriers to hand hygiene. There were economic issues we saw, such as unemployment, people being laid off, service workers being disproportionately affected, loss of health insurance, there's people with comorbidities being much sicker, exacerbations in substance abuse, mental health, intimate partner violence, child abuse. So all of this has brought health equity to the forefront. The COVID pandemic led to a rapid acceleration in the adoption of telemedicine, but the increase of the use of telehealth did increase healthcare access, and it did reduce the transmission of COVID-19 in healthcare settings. But we did see disparities in the use of telehealth by patients with lack of access to technology, limited health literacy, and these issues were especially problematic in rural areas, with older adults, specific racial or ethnic groups, people with low income, people with limited English proficiency. So quality improvement efforts must address technology-driven disparities as well as we design all our interventions. We have to make sure that as we decrease inequities, we also improve overall access of care for pretty much everyone in the communities we serve. So with that in mind, I'm gonna move on to our panel discussion. And I have a few questions for our panelists, and we will hear from each of them. So my first question, and our first panelist that will address this question is Isabela. And then the order in which we will speak is Isabela, Joel, Meghan, and then Peter. So Isabela, tell us a little bit about your current role and how health equity relates to it.
Okay. Hi, Ulfa. Thank you so much for this opportunity. And also thank you, ISQua, and to the colleagues. Well, today in Brazil, I lead a service for special care. I am a dentist by profession, specialized in special care. And today I am head of a unit in a dental company. In this role, my key responsibility is to foster and deliver care in a way that no one is left behind. especially people with disabilities. And for that, I have developed strategies for dental services, especially designed for inclusion, not just for patients, but also for the families, making sure that quality is key, even in a dental field, which is not very, this is not very, we don't see a lot of information circulating about quality in dental services, and making sure that they also have a good experience, because patient and family experience it's very important in the dental setting. So I work pretty hard to create a culture of compassion and accountability to diversity, to assist this group of patients. Compassion should be a norm. And lastly, I come from a very, just a curiosity, I come from a very diverse family. I had a very strong mother, and I have a sister with cerebral palsy. So it has always been a norm for me. I was born in an environment like that. So somehow I want to offer this everybody that I get connected in my life.
Great. Thank you for sharing that, Isabela. Joel.
Hi, thanks, Ulfat. You know, for me, fighting disparities and trying to get health equity for patients is something that's part of everything I do in my job. And so wherever I lead, wherever I teach, wherever I practice, my goal is to say, what can I do in that moment to prevent a disparity from happening to a patient? So it might be at the level of the patient interaction. It might be at the level of a publication. It might be at the level of mentorship. But it may even be at the level of policy or some of the work that, for example, leading at the American Academy of Pediatrics. But what I do is I really try to encourage people to say, what solutions do they have in that moment to address disparities, and to push back at this concept that patients have social determinants of health. What they have are barriers to health. So if you use the QI framework that we all know and believe in, then it's not some social factor that's inherent upon the patient, it's a social factor of society. And I think it's incumbent for us to say, how are we going to address that barrier so that it doesn't affect our patients?
Great, thank you. Megan, how does equity relate to your current role?
Yes, I'll just pick up where Joel left off. I am a hematologist and I care for patients with sickle cell disease, as you mentioned. And I have the unfortunate opportunity to see disparity impact my patient population significantly. And that ranges from things to just getting into clinic, as you mentioned, accessing virtual visits, or the clinic being amenable to the needs that they have. There could be a single mother that has to pick up other children and can't stay or make it to the appointment in the time that we have allotted for them to be able to pick up everyone in a timely fashion. So we see all these different aspects of struggle for our patients. And that really what fuels me more than anything else of the academic role that you listed for all of us is really about what can we do to make the healthcare system work for our patients. And this is a national issue and something that we really need to figure out. Every little thing that we do can help with that one patient that you may be interacting with then, but then take a step back and using a framework to assess what can we do to make our process better for all those that follow that patient.
Great, thank you. Peter.
So, yeah, so I'm a little different in that I'm not in pediatric practice right now. Just to say where I come from is from South Africa. So I grew up in an environment which was actually quite fortunate when you look at disparity, because it's right in your face and you could see the disparity. And my clinical practice was with children with cerebral palsy and any kind of disability, but it was a very wide range of things. And when you're working in a society in which it's quite obvious that there's going to be disparities because of the way the society is structured, then you could work more openly about how to get that done because it was right in your face. When I moved to Europe, to England, it was more understated. So what happened is no one everyone's thought, oh, we have a national health service, so everyone gets equal health care, like that equal health care showed. But of course, it depended where you lived as to what. And I'll just give you an example that when I was working at the Royal Free Hospital, I could get services for children living on one side of a street and not on the other side of a street, based by the local political decisions made by the local councils. So basically, this thing about inequity, it's something that I've been involved in all my life. And now, right now, what I'm doing as a quality improvement lead is that every project I have has to examine whether it's going to be equitable or not. And I think that is the first step. So I'm painted as part of the things that you have to measure at the start. Equity is not something you think about afterwards.
Great, thank you so much for those thoughts. So all of you have given us a great picture of the work that you do and some of the challenges that you face. Now let's zoom into maybe one big challenge. So in the work that you do, what is one big challenge to addressing health equity? So let's start again with Isabela.
Wow.
And you could address more than one, that's fine.
Well, a big challenge to address equity. I will start with the dental field, as I am dentist, and I always try to circulate this message about dental care, especially for children. The big challenge is to make people believe that they need and they deserve a good dental care. So our constitution in Brazil is clear when it says health is a health of the citizen and a duty of the state. But, you know, oral health is frequently abandoned in some cases, especially in children, in patients, people with disabilities, especially in children. It can be for lack of access, lack of awareness about the dynamic relation between the oral health and systemic health, or sadly, because patients do not find specialized dentist care for them. So I remember my sister, I am the youngest child from 4 siblings. And I remember we woke up in the middle of the night and the house was an old house with a long corridor. And my sister cried during the night because she had toothache. And my mother, my parents, they had resources. I mean, they could afford for a dental treatment for her, but we did not manage to find anyone to treat Adriana. So this is something that we should not accept nowadays. So one of the things that I do, during my journey, I have worked for Fundação Xuxa Meneghel, United Health Group. I have offered some consulting for some companies, and I have worked for Brazilian Air Force. And in every interaction that I have, even with a human being or a company or an NHO, I kind of leave a legacy, if I can call this a legacy. I leave everything ready for people move on from that point on. So, and beyond that, I incentivize and I motivate dentists to look to assist patients with disabilities. And I feel very embarrassed to say that, but in Brazil, we are just 300 dentists to assist the entire community of people with disabilities. So the challenge is to make this movement, push forward this movement on, not just for patients and families to get to know that this is a right, and also for the entire community. You should see these people, not just pretend that they are invisible.
Thank you. Joe.
Yeah, that's great. Thanks, Isabela. I think I have 2 things I want to mention. One is just building on what Isabela said is, I find that healthcare, we've got about a century worth of describing disparities. And we just describe them and we point at them and we say, there they are. Look how bad this is. And pediatricians are really good at that. What pediatricians, and I think this is probably true for dentists, Isabela is probably true for other providers, is we haven't figured out how to find solutions to address those disparities. And I think if everybody in their daily work said, I am going to do something to address those disparities, then I think we would actually solve the disparity problem. So really, my first problem that I work on every day is how to convince people to do that, use their creativity, use their power, their privilege to actually address those disparities for their patients. The other thing is a little bit more fundamental to the QI world, which are measures. How do we know if something's getting better? Well, we have to measure the disparity. And how do you measure disparities? Well, you have to classify patients based on their backgrounds, right? And those data are pretty terrible in the United States. They're difficult to get. And I imagine for other countries, they're very difficult to get for various reasons. And I think we can get those data. We're getting better at it, and we have some solutions there. But I think there's still a fundamental problem of understanding that gap, that delta that Ulfat you showed on those run charts. If we don't have those measures and they're not reliable data, then I think we struggle a little bit. So I do a fair amount of work with big databases to try to do better with those data systems.
Great, thank you so much. Meghan.
Yes, so the biggest challenges that I see with addressing health equity is a lot about, us checking our bias to some degree, being aware that we have biases that impact how we interact with other people. And I think that if we can figure out a way to move our healthcare system from a blame system and more to a systemic change system, then we can put aside our feelings a bit about how it is that we felt about an individual or a family member or something like that, and can now grow and move beyond that to make a better system work for us. And I think finding a place to start is really challenging, where the whole thing feels very overwhelming. And to Joel's point of just, if we all just do one thing to make it better, then that's going to have such a significant impact overall. And I don't want people to get overwhelmed with the data sets or, creating a database. Any work that you do, stratify your data based off of, race, ethnicity, language, ability. All these things are things that are relatively accessible within your medical record. And then you can do the things that Peter was saying, just, from the very beginning, when you have a project, it should be from the front. From the very beginning, we should be evaluating if we can address equity within these things. And it's so simple, just to stratify data based off of race, ethnicity, language, sexual orientation, if that's available. It's less available in medical healthcare systems. But that is, you can learn things. You may find something that you didn't know was a disparity, and now you have an opportunity to address that.
Okay. So lots of good information on measuring and basically building measurement into all our QI work, right? So Peter.
So the last speaker of each question gives a chance to think about the first speaker's questions. And if you really wanted to test equity, what you need to do is go to a community and ask the children to open their mouths. And what you'll find is dental caries in the very poor, those inequitable, and those who are well off will not have dental caries. And that is a very good test. Like a simple test for a pediatrician to do is just to look at the teeth of the children that they see. But there are many different ways you can do it. And I'll just reflect, so I want to give some practical ways. There's some questions coming up very nicely here about social prescribing, which we might come to later. But one of the things pediatricians can do, and there's a very nice article that I will try to put somewhere if I can, by Goody Singh and colleagues in the UK, for a checklist of pediatricians asking children about what they do. So one of the things that I used to ask children would be, did you have breakfast today? A simple question, did you have breakfast today? Or another question that we're asking right now is, where does your mum buy the food? Now, in the UK right now, the inequity is so great that people are not buying food, they're going to food banks because they can't afford to buy food. So asking people in the US, do you have food stamps? Finding a way to ask that. Just the same way, and we are here with equity, where because one of the things I used to do in the past was work with children who had been abused. And one of the things that we found difficult for pediatricians to ask was asking whether there was domestic violence at home, whether there was anything that was going on in the home. It was a taboo topic. We didn't ask about domestic violence, and we didn't ask about the child, how the child was disciplined. Just like where in the US, it's very important to ask about whether the parents own a gun, because that raises the risk of violence at home. So all of these kind of questions that we shy from, it's easier to ask about coughs and colds and things like that, but it's more difficult to ask about people's poverty and about where they eat and what they eat and how often they manage to go out and so on. So what am I trying to say? The most difficult thing for us is to ask the question. And to ask the question, we have to go to something that Meghan said about implicit bias, that we all have implicit bias. And if we don't recognize we have implicit bias, we'll never ask the question in the first place. And so I'm just going back to Meghan. I've got an advantage because I know you deal with sickle cell disease. Now, sickle cell disease does not happen in really affluent people in the upper income groups as much as it does in people whose origin comes from Africa, who has sickle cell. This is like Afro-Caribbean in the UK or so on, high levels of sickle cell, but also high levels of deprivation. And therefore, they're double whammied. They have a condition, plus they have the deprivation that's not been addressed. So ask the question. That's my first thing.
Great. Thank you so much, Peter. And moving on to our next question for our panelists. What's a quality improvement program or an intervention or a QI innovation to address health equity for children that you believe has made a significant difference? Isabela.
Yeah, this is easy. I have mentioned this I have addressed this question in my last answer. Brazilian Air Force. Well, I had a super meeting with the mother at the NICU. I had just arrived at Air Force. I was the youngest, like the freshman, as they say in the military world. And they told me to go, our dental building was in a hospital. And we had a hospitalized patient at the NICU with a very rare syndrome. And she had a condition in his mouth. And in my misery, I denied that visit, like for days, because I had had an experience, a very traumatic experience in a NICU 2 years before, 3 years before maybe. And the last thing that I want, the last place that I want to be was in the NICU. But then I finally got to go there. And I felt, first I had a very emotional identification with that mother when I first saw in the bedsides with Mateus, the name of the patient. And I had that feeling, we gotta do something. How can we be 80, almost 90 dentists in a building beside this one, and here in this building, we have a patient with the mouth in this condition. So I always advise people, don't be the wet dog. Don't be the wet dog. You know the wet dog, when the wet dog comes close to you and then you shake, everybody runs from the dog. I was the wet dog at Air Force at that week. I knocked in every door. So years later, 2 years later, the patient died because of the conditions of the disease, of the syndrome, okay? But we had improved his quality of care during the NICU. He had a major improvement, and we managed to create special care dentistry, geriatric dentistry. And I always say, it was not myself. It was the impact that Mateus had in my life. So I managed to knock in every door, and I was so boring, so boring that they decided to create everything. Hospital dentistry, home care dentistry, and I left. I left in 2016, but the services remain today. So today, instead of depend on a favor, they have this as a right. They call and arrange an appointment, and it's done. So, well, thank you, Mateus, for that.
Great. Thank you for sharing that, Isabela. That's a very poignant patient story. And I'm sure all of us right on this call have a patient story that led on to sustainable change. So we're grateful that we have these patients in our lives to keep us motivated and going. So Joel, you're next.
Yeah, thank you, Ulfat. There's a program we have at Seattle Children's that is now the New York chapter of the AAP, and then the Washington State chapter of the AAP have begun to use. So I'll talk a little bit about that program. The acronym is GATHER, which stands for Generate and Teach Health Equity Routinely. And what this program does is it's mostly for providers, and it's they're allowed MOC credit, which is in the United States, that's maintenance of certification credit for your board certification, and you have to do these QI projects every 5 years. So this project qualifies for that. But what it does is it teaches providers to self-reflect on their actions to reach health equity. And so it has some very little didactic but independent learning. And then it's followed by some self-reflection surveys. One of the surveys questions might be that you ask yourself weekly is, I used an interpreter for my patients that identify speaking a language other than English, right? So if we all did that, then we would address that barrier to language that many of our patients have. And so there's 7 or 8 other questions built in there. And then I think the unique thing that happens with this is they meet 3 times in groups of 8 to 9, where they discuss their challenges to do whatever their personal goals are in achieving health equity. So some of them are leadership, some of them are academic, some of them are clinic-based, and some of them are policy-based. And they work together to identify solutions. So anyways, I think this program, based on our data, has been quite successful. I'll put in the chat a link to the curriculum, and happy to answer more questions later about that.
Great, thank you. Megan?
Thank you. And at Riley, we actually have done an adapted version of your Gather, Joel, and it has been a wonderful experience. The group sessions have been so valuable to everyone that's participated in it. So it's definitely something to look into and consider doing at any other institution that you're interested in. For me, I would say that not a personal thing that I've done, but something that I find that would be very valuable is integrating equity, diversity, and inclusion discussions and questions in standard processes. So we've highlighted that discussing our biases are a challenge. And it doesn't feel good and people don't like to do it. So if it's integrated into standard processes, then it makes it normal. So we move from the difficult conversations and we shift towards expected and routine conversations. So things like within quality and patient safety, are you doing an RCA? Are you doing a medical error or any kind of patient safety event? It's an opportunity to integrate these questions and conversations to ask, did race, ethnicity, biases that we have, language barrier, play a role in the outcome of this patient? And it now, again, allows us an opportunity to learn from our experiences and grow and become better. I also really appreciate an article that has been published in 2022 by Dr. Casey Lyon entitled All Quality Improvement is Health Equity Work, Designing Improvement to Reduce Disparities. This is published in Pediatrics, and it really is a great piece that highlights that you should be viewing quality improvement with an equity lens, but also viewing equity through a quality improvement lens. So if you attack it from both angles, you now have a framework to address it and something that is achievable and shows you a step process to get the outcomes that you're seeking.
Great, thank you. Peter, we see you we have you back.
Yeah, I just dropped off for some reason. Inequity in my in my provision. Yeah, so just which question are we on again? Just could you just... So
yeah, in your mind, what's a quality improvement program, intervention, and innovation to address health equity with children that you believe has made a significant difference?
I'm going to use a Scottish example that I mentioned to you and an English one, because originally I'm a child developmentalist. So for me, if you really want to sort out equity for children, it's going early on in life and starting early. And what they did in Scotland, they had an early years program because they realized that one of the issues that they had was that children from lower income countries who were deprived areas were never read to by their parents, for example. And so they started a program in which they were teaching parents how to read and how to read to their children, which is a simple thing outside health. And it goes into the idea of what, there's a question there from Caitlin on social prescribing. is that most children do not spend their time in hospital and being ill. Most of them spend their time out in the community. And what we have to do is create the environment for them to grow as they go forward. So I really encourage you to look at that early years program in Scotland. In England, they had a similar kind of paid program, which became a political, I'll say it was like Head Start in the States. It was called Sure Start, and the whole idea about working on the early years. So for us as pediatricians, we often dealing with people who have illness, children who have illness. However, the vast majority of children don't ever come to a pediatrician. They are healthy children who are living in society, and that their long-term life outcomes will determine on their early year intervention. And that's where I think we really should work. And those two programs I've mentioned had really good results working on the early years.
Thank you, Peter. So, and also I see our panelists are very busy multitasking, addressing questions in the chat. So great job helping out with that. So our next question, reflecting on the quality improvement program or intervention or innovation that you mentioned just now, what are one or two key steps that ISQua and AAP co-equips members can take in their own roles to help with scaling up or spreading that innovation or intervention that you discussed? So Isabela.
Thank you, Ulfa. Well, the first one, start very, very, very small. We'll start, just do it. Start it today. I frequently meet people willing to start something, but they always, no, I'm gonna do something, but when I have the available resources, available people, start small. And you soon will find the early adopters, champions that will probably join you and believe in your idea and have, find your tribe. Second, find your tribe. Start small, find your tribe, have a consistency of propose. Small things every day. You don't need to be a superstar. I started as a dentist. I started to help patients and families. I've never thought I would be in a panelist with Peter Lachman today. He's a superstar. So with other folks like you, it's a great pleasure, a great journey, and also a great learning and a great healing. So start with what is possible. Find your tribe, have consistency of purpose, and believe. Never stop believing.
Great, thank you. And it's good to have you in the Peter Lachman fan club along with me, Isabela. So moving on to Joel. What can we do to help scale up or spread the innovation you discussed?
Yeah, I think if you are a leader, and most providers are leaders, right? So healthcare providers are leaders. Some have different levels of scope in their work, but if you find yourself in that capacity, then I think working with your organization to make health equity a priority and a value. So really, when you establish this is how we're going to operate, that you always come back to that as a value for your group. Once you do that, then like Isabela was saying, you empower the people on the front line to do the small things, which are really meaningful, but push them towards action, right? As Ibram Kendi says, the opposite, most of us aren't racist, right? We're not racist. We don't identify ourselves as racist, but the opposite of that is not racist, right? And so if you're just not racist, that doesn't mean that you're going to fight disparities. What you have to do is be an anti-racist, which is where that terminology comes from, which is you actually have to be action-oriented. You have to do things to address those disparities. And of course, not all disparities are linked to racism, but a lot are. And other things that are linked to disparities need to be addressed. And so you have to be action-oriented. So making sure that those things are part of everybody, those solutions are the part and parcel to the things that people do every day. And the other is to provide educational resources. I think there's a lot out there, but what education are we doing when people want it? How do we get it there at the right time? And then providing the mentorship for people that are ready to lead in that space and helping them also spread spread the solutions.
Great, thanks, Joel. Megan, what are your thoughts here?
So much good stuff. I would add building the culture from the ground up. Building in that educational material to ask these questions, teaching people from the very start to think about an equity lens when they're doing their clinical work and doing projects, so that way they can be aware of those things. And building an environment in which people have the grace and safety to be able to have these discussions. Before everybody joined, we talked about how these terms change quickly and that we want to make sure that we're using the right terminology. So it's important that we have an environment in which we can discuss the moving pieces and feel safe to be able to learn from each other in that regard. So that culture from the ground up is significant. And it's not going to happen overnight. And that's, again, why I reiterate back to it needs to be built in. These questions need to be built into education and needs to be built into standard processes. So that way the conversation is at first required, and then it becomes natural and regular. And that is how we will continue to change the culture or shift the culture and grow within an institution the acceptance and known entity of addressing equity from the very beginning. I also want to highlight that I'm working with Joel on creating a policy statement entitled All Quality Improvement, using quality improvement and patient safety principles to address health disparities. And this, I hope, will be a framework in which institutions can use to help figure out how to build in these standard questions to address equity within their institution.
Great, thanks. And Megan, for our audience, could you clarify the policy statement that you just mentioned? How might they be able to access it?
Yeah, it's just been approved by the AAP for a policy intent. We're currently in the drafting process of it now, so hopefully it'll be available to you in the near future.
Great, congratulations on that policy statement, Megan and Joel, big step.
Thank you.
So Peter, thoughts on scaling up or spreading the innovation you mentioned?
My response to that is that we first have to recognize where we come from to scale up. Most of us are talking about equity for two big reasons. Firstly, because of colonialism, and which caused it. And secondly, if in the USA and Brazil, because of slavery. So we forget about the history. And if you forget about the history, where we come from and why this is happening, then we'll never be able to solve the present and the future. We have to acknowledge the history. So if we're going to scale up, we have to acknowledge that most of the problems of inequity when it comes to inequity due to ethnicity or race or whatever, because race is a social construct after all, is due to slavery and colonialism. And often people have not recognized that. So that's my first step. And I know this is quite controversial, particularly in the USA, talking about history, because we'd like not to talk about the history. But unless you understand the history of why a child in front of you is deprived, you will never get there. So that's the first thing. The second one that I think is so important for scale up, and I really like the idea that I think Megan said, and both Joel, all of you said, starting small, is that you start with the next child you see in your clinic. That's your scale up, the next child, not the whole society, just the next child, and ask yourself, do I have any implicit biases? Am I culturally competent to deal with this child? Do I understand where they come? Do I ask the person, what do you want to be called? Not what I called you, but what do you want to be called? What are the things you're going to do? So my advice to most people is start with the next child you see and say, can I deal with this child? You'll make a difference for that child. There is a question about social prescribing in the chat, and I just want to deal with that now, because one of the problems of being a pediatrician is that most of the issues we deal with have got nothing to do with health. They've got to do everything around where that child grows up. So social prescribing is part of what we have to prescribe. We can't only prescribe medication and hope for the best. We have to do social prescribing, and there are many community-based organizations to help us do this in order to make a difference. And this is where we talk about not the child, but the child and their kin, the child in the wider family and community, because we have to deal with that. And I'm sure, and I can again use Meghan's example with sickle cell, because a family with a child with sickle cell, it's not this child with the sickle cells who are the problem. It's the whole family has the problem as well. And unless we deal with the social implications of that condition, we're never going to make a difference and decrease disparities. So that's my take on this in the first instance.
Great. Thank you, Peter. And then finally, moving on to our last question. And I've been scrolling through questions in the chat and in the Q&A section, and I see that our speakers have actually handled and addressed many of those questions, but I can circle back at the end and see what some of the gaps are. So my final question to you all, what is one piece of advice that you would like to, and I think, many of you have sort of said that, so maybe you could restate that. What is one piece of advice as we come toward the end of this webinar that you would like to give to people who are just starting off on their journeys to improve health equity for children through quality improvement? Isabela.
My first advice, my one and only, it's a little bit of what, thank you about what Peter just said. Have a meeting. If you are in Australia, today is already tomorrow, but put in your agenda to have a meeting with your leader to start something for the children tomorrow. Put in your to-do list, like important thing. And like Peter said, one child at a time, one day at a time. I have some memories of when I was a kid. I should be like 6 years old. And I remember how encouragement I received from some teacher and how discouraged I was from others. And in terms of equity, it can make a huge impact on how this person will become an adult and a strong adult. As I said, I had a very strong mother. I am so lucky I had this woman in my life. I was never told that I was a bossy girl. I was always stimulated to be a leader, to make questions, to be curious. And today this might be a problem for some leaders, because I always, like Meghan said, raise your hand, make the concerns, address the issues, make people know the unconscious bias. We are creating a new generation of people. If we do our job today in a good way, in a good and compassionate way, maybe in the near future, in the middle near future, we are creating a new environment and a better one for the generation that is coming, the children, the adults in the future.
Great, thank you. Joe, your thoughts here?
I love that answer, Isabela. If you're just beginning this journey, then I think you need to read and you need to do some learning in this space. And it's not passive learning, and it's not easy. It will be painful, and I think you'll have a lot of realizations when you do it about how you were brought up, like Peter was saying, maybe in a colonial area where you were of the privileged class and you didn't realize what that meant for those of the other class or the other races and ethnicities. And so you have to realize that as a starting point and be ready for it, embrace it and take it in. It will change you. I put in the chat box Ibram Kendi's book, which I think is just foundational to doing this work and learning how to lead in this space. They have books, he has books on tape, and he actually has some action plans for organizations and things like that in later editions. So I think starting there, and again, this is active learning. So I encourage you to do that work. And then also in the gather list of resources, you'll see lots of readings and different media types for you to start that journey and go deeper.
Okay, thank you. Meghan.
It's going to sound a bit, redundant, but, as Gandhi said, be the change you wish to be in the world. Do something, make a difference. The sum of all of our small actions can impact the culture around us and have a ripple effect. And the sum of all of that can really shift us to being more accepting and welcoming. Again, I just want to also go back to just, again, the simple thing of stratifying your data through race, ethnicity, and language is an easy thing to do just to get an idea of what is happening in your field of study, rather your patient population and your institution. So I'll keep it short. Just be the change you want to do, do something small, and it has an impact.
Great, and Peter.
Yeah, so just tying it all, and I want to tie some of the questions that over there in the Q&A. Look, you have to first acknowledge there is a problem. I think that's the first thing. You have to acknowledge there's a problem. That is actually the most difficult step of all, is acknowledging we have a problem. Because often, if you had to go around to pediatricians or to doctors around and say, do you teach everyone equally and deal with equity? They say, sure, I do. And that's where the problem is. They haven't acknowledged that they've got a problem. The second one has acknowledged that whether we like it or not, we all have prejudice, whether we like it or not. And I mean, the only time we have a problem is when we say we don't have any prejudices and we treat everyone equally, because we don't do that. We'd like to think we do. And I would always ask after I saw every child, I would say, and every child who did not look like me and did not come from my social class, I would say, did I treat them equally or with equity in mind? Did I ensure that I was doing the right thing, or did I treat them as if everyone was equal, which is the wrong thing to do? You've got to really deal with it. So that's the first thing, is acknowledge. The second thing, I've got to stress this, what Meghan said, is you have to measure. You have to measure your outcomes to demonstrate that you have equity in mind. If you do not measure the and there are questions coming in, I'm giving out my email address. People can email me at any time, and I can lead them onto their way. Because one of the things is, Ulfat and I did a lot of research and writing a chapter now in the new book on quality improvement on equity. So we've got lots of things to share. And the policy that's Meghan's talked about is going to have a lot of that as well. And I saw on the Gather program a lot. Now, the thing is measure. So and then educate yourself. Okay, that just like Joel said. And the last one is something that came out very early on, is that Joel said that as being doctors or nurses, we are leaders. So you can lead for equity. But in order to lead for equity, you have to make a choice to lead for equity. And I'm asking all of you around the world to make a choice. I do a lot of work in Ethiopia, Mozambique, now Sudan, South Africa, etc. And I see a lot of inequity, but I see a lot of people making the choice to lead for equity. And if we can do that, that will make a difference.
Thank you, Peter. Really well said. And as we close this webinar, I'd like to share this resource that Peter was mentioning, the upcoming OUP handbook on quality improvement. I worked with Peter to help create a chapter on health equity and QI. And with Peter's permission, I'm sharing this acronym. The book has not yet been released, but sort of this is since you're on this webinar, we're going to share this with you, but he has this acronym, Square Deals, where everyone receives square deals, because now, our health system is fairer than it was before, where we look at our systems, assess healthcare delivery, our financing systems, our healthcare infrastructures. We quantify and measure, really important. You saw this theme coming up again and again today and from multiple panelists. Collect, report, and disseminate data on disparities, and then pass it on to decision makers and the public. Unify and integrate. Consider how integrated models of care can address inequities. Acknowledge, this came up as well, be aware of your biases, ensure cultural competency, recognize disparities, raise the consciousness of our biases against those who might be vulnerable to them. And consider how QI interventions affect diverse group. Engage people, their families, and the communities. I saw someone in the chat asking about engaging children, so engaging the families of the children we serve in co-designing quality improvement projects and programs with us, defining, so calling out inequities and disparities, and then engaging and co-producing with our communities, our families, stakeholders, and patients. Asking and being curious, always being curious. Joel mentioned this, a lifelong learner. I work with Joel on and Meghan on the Council on Quality Improvement and Patient Safety with the AAP. And I, even after years of working in QI, was a novice in this space and looked to Joel and Meghan to educate me. So, we're lifelong learners at any stage in our lives. So always be curious. And if you do not look or ask, you will not find inequities. And then leadership for equity at every level. Isabela brought up how she emerged as a leader in this space, right? So, and then finally study and analyze and track data through an equity lens, integrate equity into quality dashboard. While designing your QI project, make sure to design for equity and make sure that we don't make equities, basically inequities worse with the work that we do as well. So with that, I would like to thank our panelists. I was hoping we could maybe spend a couple of, I know we've gone over time, but I wanted to make sure that all of the questions were in the chat and the Q&A section were addressed. And I think that they are. We've spoken about co-design, we've spoken about social prescribing, and let's see. Yep. So, and several resources. I see that Joel has placed links in the chat. So we'll have Katrina maybe compile those links and send them out to participants. Before I close this webinar, just one request to all of you in the interest of quality improvement. We would like to keep working on elevating the quality of these ISQua AAP COQUIPS webinars. We do hope that these are ongoing. So you will receive a survey with just a few handful of questions from Katrina after this call to give us feedback on how we did, how the speakers did. So if you might complete that, that would be really immensely helpful. So with that in mind, I'd like to close this webinar. A big thank you to all of you, Isabela Castro, Joel Teeter, Meghan Drayton-Jackson, and Peter Lachman. I learn from you every day. Thank you for being my teachers along this quality improvement journey. Have a good day.